true GRITT fashion of Mount Sinai, Dr. Dubinsky will be delivering Dr. Kiefer's talk on managing behavioral health in IBD.
Great, thank you. So I don't consider myself to be a GRITT expert, but I'm going to try my best. And even yesterday at the bookstore, I bought a book about GRITT, which says it's all about passion and perseverance. So I'm going to try and be passionate and persevere through Lori's wonderful work. And the reason why I think we should always never forget the impact of behavioral health on IBD, setting the background that we know that the data suggests that about 50%, particularly Crohn's patients, have secondary functional GI symptoms, even in the face of complete transmural or deep remission. So the importance of over-treatment and or under-treatment in the context of not understanding the impact of behavioral health on IBD is cannot be understated. All right. So a more recent publication that's out there that talks about the fact that physician and patients there's a clear disconnect. Now, we on the clinical side know that how patients define remission, even clinically, is very different than how we would define remission. This flare concept is a constant dialogue about, I had 5 flares over the last month. What does that even mean? It means that you had a few loose stools or you had some cramping that could be not even related at all to the underlying biologic process. So this was a publication that showed the difference between what IBD patients and providers with respect to their psychological concerns. And if you look particularly on the patient need versus what was actually discussed, no one should be shocked at the idea that the impact of IBD on mental health, which is what the patient feels they need to talk about, is only addressed 1/3 of the time by providers, and the IBD impact on emotions. So we definitely know that patients want to talk about it. There was a global survey that was done actually through Pfizer called UC Narratives, which was about 1,000 physicians and 1,000 patients globally. And they asked what were like the key points of UC, because Pfizer, this was on label for ulcerative colitis prior to tofacitinib launch in May, was the idea that what are the things that you most want to talk about with your doctor that you don't? And it was how exhausting IBD could be, and how if we ask too many questions, we fear that we're going to be one of those pain in the ass patients, and the physician's not going to want to answer our questions. So not having enough time, being annoying by asking a lot of questions, particularly about the impact of IBD on their mental health. So we know this is a big part of understanding the care of an IBD patient. There was a systematic review of the comorbidities of depression and anxiety with IBD, and again, this was published a couple of years ago, and they looked at the level of evidence, which as you can see is moderate, which is far better than the level of evidence we have for even reactive TDM. So I want to put in the context that no one's putting guidelines together or a consensus statement on the impact of IBD on the emotional health, yet we're putting out papers that are out of date by the time they're published, such as the TDM guidelines. So when you look at what are the prevalence of depression in IBD versus general population, you could see the first was just general pop, 21% in IBD, 13% in the general population. Active disease, more patients tend to have reactive change in their emotions when they're active, but again, that's not surprising that when you're active, it's depressing, especially when you come out of a state of inactivity. It didn't look to be that Crohn's disease was any different than you see in description of the impact of the disease on anxiety and depression, and also other chronic diseases, which is very interesting that IBD had a less rate of depression and anxiety compared to other diseases, which is the first time I ever saw IBD highlighted in a positive way when we talk about the impact of disease. And one of probably the most important things, and Dave Binion really, and the group of Pittsburgh were really instrumental in talking to us about that a small percentage of patients take up the bulk of the cost. And this has been an ongoing dialogue for a long time, that we know those patients who we call frequent flyers, patients who are often visiting the ED, a lot of after hours phone calls driven by no one called them back during the working hours, the anxiety around any flare or change in symptoms, someone getting back to them right away. But the The problem is that the bulk of the expenditure is really driven by factors of behavioral health in the background of IBD. And so I think the underestimation of anxiety and depression and how it drives healthcare utilization is really a strong statement to be made. We now know that outpatient care for IBD has just surpassed inpatient surgical care for IBD. So we know that medications are expensive, and we know that managing patients on the outside is now more costly than managing patients on the inside. So the idea that healthcare utilization and minimizing healthcare utilization and understanding what are the barriers to keep patients from not using EDs and narcotic use. I mean, at DDW, if you looked at what was hot at DDW in 2018, there was a lot about opioid use in IBD. It was the first time, because we do a best of DDW as part of Cornerstone, and we know 1,000 abstracts for the last 8 years that get submitted. This is the first time that we actually included abstracts on opioid use, not because we didn't want to historically, there was none. And this was really highlighting the fact that this is sort of becoming a big problem, especially people who get narcotics early on in the first year of IBD management. That becomes a pattern for over 1/3 of our patients. So this is like a really important aspect to understand, that what drives narcotic use is understanding the background of whether or not patients have depression and anxiety. So if we don't appreciate the impact of behavioral health on having IBD and then the downward effect as it comes to also narcotic utilization, we're missing a huge window of opportunity. And again, the main drivers are chronic pain, narcotic use, depression, and low social support. So we also know that in the absence of confidence, self-management, self-care, resilience, grit, what we call bounce back, without that perseverance, the idea being that we won't be able to get patients who were basically pushed back at any point. Imagine sort of that Bobo doll concept of a patient constantly being pushed back and the inability to bounce back. And that inability to bounce back is what really drives healthcare utilization costs. And so we really need to understand how important it is to really impact the role on mental health, or what we call psychosocial impact of the disease. We know that the symptoms of depression overlap with a lot of the symptoms of IBD, and hence why I was getting to at the beginning that if we don't understand the secondary effects of IBD on symptoms that mimic, it often leads to overtreatment. Talk about forgetting using KT Park's TDM model that predicts you need 20 per kilo. Patients who have completely normal labs, never scope, but have persistent symptoms on 40 milligrams of prednisone and escalated to 15 to 20 milligrams per kilogram of infliximab because of persistent symptoms that are due to non-IBD related but functional related symptoms. So the healthcare utilization costs that are associated with our lack of understanding of the synergy between the brain-gut axis in patients with IBD is really, we're seriously under managing a bulk of our patients. So it really makes it hard to manage IBD because these patients, as I noted, are constantly regarded as patients who are we're just not able to, when you roll your eyes as you walk into a room, you know that patient because you can expect, what's going to be the conversation, but you don't do anything proactively about it. You just keep rolling your eyes every time you go and see this patient. We all have those. But the ability to actually utilize some of our psychosocial support is really important. I think this talk lends itself nicely to the debate that Ashish and Robin just had, which is really about this proactive versus reactive. So we could wait for patients to become depressed or anxious and impact healthcare and say, I don't know, I can't predict who's going to have these issues, and be reactive and refer on as patients' anxiety and depression becomes a thing, meaning maybe instead of saying we want to identify those who have depression and anxiety, why don't we take a proactive approach and say, how can we prevent patients from developing depression and anxiety? How can we identify these patients early and screen them? So I think one of the things that we know is that patients need a toolkit. They need a whole bunch of tools. That doesn't mean they need all of them, but if we don't provide a toolkit other than show up your infusion, collect a CalProtect, if you ever hear yourself what you're telling an IBD patient who may have an underlying anxiety already around just life, not even disease related, telling them that at week 14, I'm going to check a drug level, I'm going to wait for that to come back, get a calprotectin, because I'm going to follow, like, it's noise. You know, they already are anxious about the fact that they have pain or diarrhea, and we're just adding a whole bunch of new level of anxiety if we don't give them the toolkit to be self-effective and self-manage. So Lori developed a method called the GRITT method, which is gaining resilience in transitions through IBD. It really was to sort of develop early on some self-effective psychological care for all IBD patients. It's really giving them the empowerment of being self-effective and to be able to self-manage. And Robin will talk a little bit about how important it is to be self-effective and self-manage if you want to have a successful transfer of care. I say that more than transition, because transition is sort of very loose in its terminology, but we're talking a hard, effective transfer. What do we need to do? And part of it is also understanding whether or not, forget whether a patient's 18, let's just say, is this patient self-effective? Can they actually take all the things we've just taught them as pediatric gastroenterologists, have them sit in the chair of the adult gastroenterologist and tell them exactly what they need in order to continue to be self-effective? So the GRITT method really has a multi-layered approach where, I'll be honest with you, when Lori organizes her GRITT team, the physicians are actually not in the room. So every Thursday at noon, she meets with everybody else in the center and kind of tells us whether or not we need to get better at helping these patients be more self-effective. And part of the toolkit, we're actually not involved in the toolkit. And basically, she developed a method where the higher the GRITT score, the more self-effective and confident you are to be able to manage your care. And so those patients who have a low GRITT score basically go into a 1-year intensive resiliency program where they basically give them a toolkit to, at the end of the year, you graduate and you're resilient and you can then therefore take over your care. And she sort of has this timeline where she's been able to enroll patients. I'll show you some of her data, but essentially it is a boot camp, and it's made up of different segments or domains, because, for example, if you identify that a patient is nutritionally deficient, you need to have a nutritionist, not a social worker or a psychologist. You know, you have to understand that there's many different domains to resilience in IBD patients. And her concept really of treat to target is, her philosophy is, if we can identify those patients who have low GRITT or low resilience, we can teach them the skill set to decrease depression, anxiety, and healthcare utilization. And so her target is to diminish depression, anxiety in our patients. A lot of the GRITT targets are based on confidence. So how even GRITT became a reality is that our dean at Mount Sinai, he's a neurobiologist, and he's all about resilience. And resilience has really mainly been in the realm of sexual abuse or trauma, physical abuse, patients who have overcome the odds after a traumatic event. No one has ever really looked at it in the face of chronic disease. And you know that over the past couple of years, resilience has sort of become something very sexy. I mean, we never really talked about that in our space. And this woman who I bought this book has a character lab in Pennsylvania, and the ability to look at all the different characteristics of building your character. Okay, and resiliency, or GRITT, is one of the characteristics that she teaches people, and she's used it for professional athletes, etc. Anyways, next time I see you, I'll tell you if I built up my character. But so the ability is that you need to be optimistic, you need to be confident, you need to have a social support. So I said to my dean, what's the one thing that builds resilience? And he said, optimism. And I said, well, how do you show optimism to these women, for example, who've undergone significant abuse? And she said, through mentorship. She said, if you have someone where someone looks up to and feels optimistic that I could be that person, that really has changed in the world of resiliency. So it was a very interesting thing to understand how we can take that to the chronic disease state and building up the ability to have social support, optimism for patients, and build their GRITT. This is sort of the GRITT scoring tool, which is her dividing up into sort of general health, resilience goals, your independence goal, and your just sort of across overall your care paradigm. So it's interesting to see, and we'll see what it means. And essentially, after you've been scored, you get a whole GRITT plan. So they have a GRITT coordinator who says, okay, you need to meet with this person, you need to see our nutritionist, you need CBT, you need hypnotherapy, you need to see our pharmacist because you have polypharmacy, you need to understand the role of marijuana in your chronic pain state. I mean, there's a lot of interesting things that they're looking at. So I think one of what we'll look for with Lori's care plan is really what's going to happen to these patients and whether or not we do manage healthcare utilization better. Interestingly, she uses a lot of telemedicine because you can't, and she does a lot of hypnotherapy through telemedicine. So I think, you develop sort of a digital psychiatrist or a digital psychologist in the world of telemedicine, and there's a lot of apps, as you know, that patients could do deep breathing, they can do self-regulation. Lantern, which is a company that actually just folded, unfortunately, and was acquired by University by Pittsburgh to actually start to have an online cognitive behavioral therapy sessions using this app for patients who have depression or anxiety. And at DDW, they actually randomize patients to this app versus talking to someone in your standard of care, and they actually showed that patients who used the app obviously had better outcomes. So the ability to actually have digital psychiatry has actually impacted healthcare utilization. This was at University of Pittsburgh, so we'll see what the future holds. So far in a year and a half, this is the data on 170 patients, and basically any specialist in the IBD center at Sinai sends them. They either could be eligible or not, and if they're not engaged, then there's no way they're going to be committed for a year to get themselves together at the end of a year and build self-efficacy. So here's the 80 patients that she evaluated for acceptability and feasibility, which is just showing you the median number of visits for the team is 8 in that year. So this is like an intense program. These patients have to actually be constantly engaged. And then 60% of patients met the criteria for graduation, meaning they graduated and they were empowered with resilience at the end of it, which I think is kind of cool. On the median age, this is 34, so this is mainly for our adult population. And 58% of the patients were female. So not all patients were female, because there's this concept that female patients with IBD have IBS more than male patients. We had a slight increase in that. And the baseline GRITT score was 45, and the 6-month GRITT score was 78.4. So there was definitively, in 6 months, you can actually empower someone, teach them skill set to make them resilient. Because a lot of people didn't know whether or not you can actually impart resilience on somebody. You can imagine that someone who has a lot of grit, but they're constantly beaten down, they lose a lot of it. So how do you get that back to a patient who has an underlying sort of grit within them? And so this was kind of interesting that you can teach it, and basically that the lower your GRITT score, the more ED visits, the more hospitalizations, and the more length of stay. So these numbers are actually, orgasmic to the healthcare, to your people, the population health, and all of your administrators at your hospitals, because that's what they want to know, is whether or not does a program exist, like a medical home specifically for IBD, that could actually improve outcomes. So essentially, as the work continues, but I want everyone to understand the concept that your job will be a lot easier if you actually ask your patients if they need help, because they will reduce the utilization, they'll reduce the phone calls, and they'll reduce complications. To be completely honest, these patients will not be, hopefully, not as dependent on prednisone and narcotics, which we know are really the biggest issues that lead to complications in our patients, and even mortality. And so we need to understand this, and that rather than the negative psychology approach, which is, are you depressed? Are you anxious? Do you need an SSRI? Do you need to see a psychiatrist? Why don't we establish and screen our patients up front? Are you at risk of depression and anxiety? And whether or not we can actually sort of impart resilience into you. And so I think we'll stay tuned for Lori's next move, but I think this is an exciting time in IBD in terms of approaching and understanding the psychological care to improve our overall approach to our patients. So thank you so much for your attention to this.